Thank you very much, Dr. Rai. I'd like to thank the organizers of the meeting for allowing me to speak today, and thank you to all of you for coming. So I'll be discussing briefly about novel agents in older patients with CLL and whether the approach should be different than younger patients. During this short talk, we'll discuss some of the challenges in the care of older patients with CLL, data from the frontline CLL studies that are most relevant to the older patient population, and then ongoing studies for these patients. So CLL, as you all know, is a disease primarily of older patients. The median age at diagnosis is somewhere between 70 and 72, depending on where you look, and about 3/4 of patients are diagnosed after the age of 65. However, despite the prevalence of comorbid medical conditions and other potential causes of death in this age group, CLL remains the primary cause of death for patients diagnosed with CLL, regardless of age, and we know that older patients are treated for the disease at the same rate as younger patients. There are, of course, considerations in the older patient population which are similar to those patients who are younger that have multiple comorbidities. The biggest thing is that they are likely to have other medical issues besides just the CLL, and things that result in decreased organ function, primarily decreased kidney function, but also cardiovascular disease, diabetes, things like that. A study that was pretty remote suggested that about 1/4 of patients over the age of 65 would actually be ineligible for most clinical trials based on kind of standard guidelines. Performance status has to be taken into account, and besides just performance status that you can see in the office, can they get up and walk around the room, get up from a chair, you also have to think about whether they're going to be able to come for multiple appointments, whether they have the mobility and the ability to sit in a treatment chair for hours on end, whether they have people who can drive them to and from appointments. And then finally, although we are kind of focused on chronologic age, we really have to think of patients not only with their chronologic age, but also physiologic age. And when we're thinking about these older patients who appear very well in the office before you start them on treatment, how are we actually going to change their physiologic age with our treatments? So we've known for many years that older patients and younger patients are not equivalent when we treat them for CLL. This was known as far back as the CLL-5 study, which was run by the German CLL study group. And as a predecessor for this was the phase 3 randomized trial of fludarabine versus chlorambucil, led by Dr. Rai, which showed that fludarabine was superior to chlorambucil. However, in this study, where patients greater than 65 were the focused patient population, we actually saw that those two drugs were equivalent. So chlorambucil was just as good as fludarabine in patients who were older. And when you look at overall survival, it actually trended towards favoring chlorambucil. So based on this study and based on multiple opinions that we really needed to focus on older patients, because when you focus on all comers, you generally accrue almost all younger patients. There have been a number of clinical trials developed focused primarily on the older patient population or the physiologically older patient population. The first of these in the era of targeted therapies was the Resonate-2 study. This study was a phase 3 randomized trial. It accrued 269 total patients aged 65 and older and randomized to ibrutinib or chlorambucil. At the first time that this data was presented, there was a median follow-up of 18.4 months, and very unsurprisingly, ibrutinib performed better than chlorambucil, with an 84% lower risk of progression or death with ibrutinib. And at 2 years, 89% of patients remained progression-free. And this number, around 89%, you'll see pretty consistently throughout the phase 3 study, so I think is a pretty good estimate of what percentage of patients are going to be alive and progression-free at 2 years if you're looking at the older patient population. So that takes us to the AO41202 study, and Dr. Kay kind of explained to you the genesis of the study. So this trial was designed for older patients to compare what we thought was the gold standard chemoimmunotherapy regimen in this patient population, which we decided was bendamustine plus rituximab, compared to 2 ibrutinib-containing regimens, either ibrutinib given as a single agent or ibrutinib given in combination with rituximab. Obviously, a second question of this study was whether there was any benefit to adding rituximab to ibrutinib. This study, in contrast to the E1912 study, did allow patients with 17p deletion and did have a crossover. So these are the characteristics of the patients. A total of 547 were enrolled. The median age was 71, and that was pretty consistent among all the arms. About 6% of patients had 17p deletion, 19% had 11q deletion, 10% were TP53 mutated, 53% were ZAP70 unmethylated, which we had used as a surrogate for IGBH mutational status because it was something that could be performed in real time. And then 61% of the patients we were able to test were IGBH unmutated. As well, kind of surprising to me at the time, 29% of patients in this previously untreated patient population had a complex karyotype, which is 3 or more cytogenetic abnormalities. Our primary endpoint was progression-free survival, and you can see, as expected and as you know, that ibrutinib regimens performed better than chemoimmunotherapy. There's a hazard ratio of 0.38 for the ibrutinib rituximab versus BR comparison and 0.39 for the ibrutinib alone versus BR comparison. There was no difference at all between IR and ibrutinib. And at 24 months, in the BR arm, 74% of patients remained alive and progression-free. In the ibrutinib arm, 87%, and in the IR arm, 88%. In the subgroup of patients who had deletion 17p, this difference is even more pronounced, where at 2 years, 0% of the patients in the BR arm remained progression-free, whereas patients in ibrutinib or IR had a very good chance of being progression-free at that time point. When we looked at our very best risk patients, and those would be the ZAP70 methylated patients in the entire patient population, and the IGBH mutated patients in the subset that we tested, we can see that those arms are much closer together. And there, at this time point, is not much difference in PFS among the 3 arms, although I think in the IGBH mutated patients especially, you can see it looks like the curves are starting to separate, but we'll have to see what that looks like with longer follow-up. There was no difference among the 3 arms at this time in overall survival. When we look at grade 3 or higher adverse events, we see some of the same trends as you saw earlier with the ECOG study, but a few important differences. We did see that hematologic adverse events were more common with bendamustine rituximab than with either of the ibrutinib-containing arms. Non-hematologic toxicities trended towards being higher in the ibrutinib arms, with some of the specific toxicities we know associated with ibrutinib seen more predominantly. And those are things like atrial fibrillation, which grade 3 or higher was seen in 6 to 9% of the ibrutinib-treated patients. Hypertension, 29 to 34% in the ibrutinib-treated patients. It looks like some of these toxicities, like the atrial fibrillation and hypertension, are probably higher or probably seen more often in older patients than younger patients. We do have to remember that the baseline incidence of these AEs is higher, but at least I think most people's experience is that older patients seem more likely to develop atrial fibrillation. The hypertension I'm not quite as sure about, but probably a little bit more likely in the older patients. And then we had a category in this study when we were looking at the causes of death for these unexplained, unwitnessed deaths, and these were exactly what they sound. We didn't know why the patient died. They were, found unresponsive. Something else happened. That was not different between the three arms. We know that ibrutinib has been associated with ventricular arrhythmias, so we would expect that there potentially are more arrhythmias in this patient population too, or lethal ventricular arrhythmias, but this did not exactly come out at this time point. The Illuminate study is the other phase 3 trial that was primarily designed for older or physiologically older patients with ibrutinib versus chemoimmunotherapy. The study eligibility included patients age 65 or older, or those who were under 65 that either had high comorbidity index, low creatinine clearance, or high-risk disease, although I believe all of their patients were actually older. Patients were randomized to either ibrutinib plus obinutuzumab or chlorambucil plus obinutuzumab. Their patient characteristics actually were pretty similar to what we saw in the last study. In the ibrutinib arm, the median age was 70. 12% of patients had 17p deletion, 12% TP53 mutation, and 62% were IGVH unmutated. Progression-free survival, as we would expect, was higher for ibrutinib plus obinutuzumab versus chlorambucil plus obinutuzumab. At 30 months, 77% of the ibrutinib obinutuzumab patients remained in remission versus 16% in the other arm. This is actually a little bit lower than what we had seen in some of the other studies of either ibrutinib or IR. And I don't know that we have a really good idea as to why this study looks different in this patient population. But again, with longer-term follow-up, we'll see whether the studies appear more similar. Here's the forest plot for the Illuminate study. Again, as Dr. Akea explained when looking at the previous one, we're looking at different subgroups of CLL patients and whether in that particular subgroup the trend for progression-free survival favors the ibrutinib or chemoimmunotherapy. And we can see here that basically every subgroup does better with ibrutinib plus obinutuzumab, with the possible exception of the group without high-risk disease. Grade 3 adverse events in this study, the hematologic toxicities were potentially like a tiny bit higher in chlorambucil plus obinutuzumab, not quite as different as when you use more aggressive chemotherapy regimens. Atrial fibrillation, as you would expect, was seen more commonly in the ibrutinib plus obinutuzumab arm. So what do these trials tell us? First, ibrutinib plus rituximab, and ibrutinib plus obinutuzumab are more effective than standard chemoimmunotherapy in a primarily older patient population. Ibrutinib monotherapy is probably just as good as ibrutinib plus a CD20 monoclonal antibody, with the caveat that ibrutinib versus ibrutinib obinutuzumab has never been studied. And these studies establish ibrutinib as one standard of care for frontline CLL for older patients. That brings us to the CLL14 study, which Dr. Kay already mentioned briefly. And this was the most recent phase 3 trial in frontline CLL designed primarily for older patients, but this included any age that had a high comorbidity index or a low creatinine clearance, which again is going to kind of naturally select for the older patient population. Patients were randomized to chlorambucil plus obinutuzumab versus venetoclax plus obinutuzumab. And when thinking about these two novel therapies, regimens, one big difference here is that the venetoclax in this study is only given for 1 year, so it's a finite duration of therapy. Patient characteristics, median age was 72 in the venetoclax plus obinutuzumab arm. The range is a little bit higher, so they had some younger patients down to age 41 and actually up to age 89. Most patients had a high comorbidity index, the Sears G score. 8.5% of patients had 17p deletion, 11% were TP53 mutated, and 60% were IGVH unmutated. Progression-free and overall survival favored venetoclax plus obinutuzumab. Median follow-up at the time the study was presented, it was 28.1 months. So that's about 1 year on therapy and 1 year off therapy, which I think is important to keep in mind. At 24 months, progression-free survival was 88% with venetoclax plus obinutuzumab. And again, when you're kind of comparing apples to oranges, but doing these kind of cross-trial comparisons of fairly similar patient populations, 88% here is fairly similar to what we see with ibrutinib at 2 years on most of the other trials. Adverse events. Venetoclax plus obinutuzumab appears actually fairly similar to chlorambucil plus obinutuzumab in terms of AEs. Hematologic toxicities were fairly similar. Numerically, I think there's a little bit more neutropenia in venetoclax obin, but there was no comparison of whether that was significant or not. Non-hematologic toxicities as well were pretty similar between the two groups. There was a little bit more diarrhea in the venetoclax plus obinutuzumab arm. I highlighted neoplasms as being something that was numerically higher with venetoclax plus obin compared to chlorambucil plus obin. Again, this it's very short follow-up. The category includes benign plus malignant too, so may not be actually representative of something that is clinically important, but something that will be followed in long-term analysis, I'm sure. So what does this trial tell us? First, venetoclax plus obinutuzumab is indeed more effective than chlorambucil plus obinutuzumab. Toxicity is pretty similar between the regimens, showing that venetoclax plus obinutuzumab is very well tolerated in this predominantly older patient population. Like I said, at 2 years, the PFS for venetoclax obin is pretty similar to what we see with ibrutinib. And I think long-term results for this study will be critical to determine the place for this regimen in clinical practice, but it is a standard of care regimen. So some special considerations for older versus younger patients with these options. And I think, in general, the options are pretty much the same for older patients and younger patients. You still can use chemoimmunotherapy if you'd like to in some patients, although I think the trials would suggest that all patients would probably do better with either ibrutinib, potentially ibrutinib with an antibody, or venetoclax plus obinutuzumab. When we're looking specifically at older patients, we'll see a lot of patients who have cardiovascular disease. There really isn't any guideline that says that patients with coronary artery disease or congestive heart failure would necessarily do better on one regimen or another. However, given the arrhythmias that are seen with ibrutinib, I think for somebody who has a history of arrhythmias, ibrutinib is probably not the best frontline option, and better choice would be a venetoclax-based regimen, potentially acalabrutinib when that becomes available as well. Patients with poorly controlled hypertension, that might be an issue when using ibrutinib. Certainly it can be tried and see how they respond, but for those patients as well, it might be a better choice to use venetoclax plus obinutuzumab. And then those who need warfarin, so patients who have a mechanical valve and have to be on warfarin anticoagulation, those potentially who have antiphospholipid antibody syndrome, people who need that drug, all of the BTK inhibitor trials, except for the initial ones, excluded patients on warfarin. So I think for those patients, venetoclax is probably a better option. Whether that extends to all patients who are on anticoagulants, probably not. And then for patients who cannot tolerate hydration, those who have kidney disease, those who have congestive heart failure, those who just are older and can't tolerate hydration, venetoclax does require some hydration during the ramp up. So for those patients, a BTK inhibitor may be a better option. And then, as I've said multiple times, I think long-term follow-up from these current studies really is going to be critical. One thing that it will tell us over time is whether there are any signals towards infectious issues or secondary cancers with any of these regimens. These tend to affect our older patients disproportionately and really could tip the balance one way or another in terms of the preferred frontline option. So Dr. Kay mentioned this study already too. This is the successor study to the Alliance trial. This is A041702, designed in collaboration with the ECOG group who is looking at the younger patients. This trial is designed for patients age 70 and older. And similar to the ECOG study, patients are randomized to either ibrutinib plus obinutuzumab or the triplet of ibrutinib plus obinutuzumab plus venetoclax. Key differences here, so 17P patients are allowed in this trial. And in this study, all patients will be treated for 1 year and then will undergo a response assessment. Patients who are on the ibrutinib plus obinutuzumab arm will continue ibrutinib indefinitely. Those that are on the triple therapy arm, if they have an MRD negative CR at 14 cycles, which is about 12 months, they will discontinue ibrutinib. If they do not have an MRD negative CR, they'll continue ibrutinib. This time point was chosen based upon our initial triplet study where we used the 1 year duration of therapy. So this trial is really testing, obviously, what's best for older patients in terms of these frontline options, and as well as looking at how a response-adapted strategy of discontinuation would perform. So if you don't have this trial open at home, please consider opening it. It's available through the NCTN and should be pretty quick to get up and running. So in conclusion, there are indeed special considerations to therapy in older patients, and clinical trials really need to address chronologically or physiologically older patients in dedicated studies. I didn't really talk about this much, but prior to the CLL-11 study, which was one of the first ones designed for older patients, the median age on all of our frontline studies done in the United States was about 65. So really, in order to tell what's best for the majority of these patients, we have to dedicate studies to them. Geriatric assessments or surrogates are really important when designing these studies to kind of differentiate those chronologically older patients into more and less fit. Long-term follow-up studies is going to be critical, and our prospective clinical trials remain extremely important to help determine the optimal frontline therapy. So with that, I'll end, and I'll be happy to take questions at the end of all the talks. Thank you.